Hello, I'm standing here with Dr. Malice and Dr. Dua, enjoying our time at the VEITHsymposium this year. And first of all, I want to say thank you to Frank for bringing us all together again. It is so good to be back in New York City, together with old friends and making new friends, making new collaborations. There's so much that goes on here, both in the meeting space and outside, that it's really invaluable to our practice here. And thank you so much for making it all happen. I wanted to talk, though, with Dr. Dua and Dr. Malice about TCAR. It's been a hot topic here for quite a while now, and even more so now that it's approved for standard risk patients. So I wanted to ask both of you. First, Dr. Dua, let me start off with you. Are you doing any transfemoral stenting anymore, or do you all do TCAR, and why?
Thank you very much. Great question. Honestly, I don't do any transfemoral stenting anymore at all. The stroke risk isn't worth it, and that's been documented that clearly TCAR does have a decreased stroke risk, and it's also, I find, significantly easier. And it's a much quicker procedure. We're all up in the neck. It allows, with the whole training paradigm aspect of it, a good exposure for our trainees to be able to do that as well on top of everything. And a very, very small incision for the patient. And if ever the patient needs to go on to have something like a CEA in the future, you've left your plane open for you to be able to do that as well. So there's really no disadvantage to doing it with TCAR versus transfemoral, and so that's my practice now.
Do we need to train our trainees in transfemoral stenting? Is there any need for anybody in the future to know how to do this?
Nice loaded question. I do think it's worth knowing how to get access and how to manage, because in a situation where you would need to do a transfemoral stent, potentially even something like a trauma, for example, where somebody's working up at the head and you need to be down below, it's good to know how to manage the stroke risk and how to maneuver to get into those areas. And not necessarily just about the stenting in and of itself, but some of the actual, what we would call exposure and open, but getting there, when you're doing endo is important. I think if there's a decision point, we need to explain to our trainees that really TCAR is the way to go, especially because of that stroke risk.
That's great. Dr. Malice, let me go to you now and talk to us about CEA versus TCAR. Is carotid endarterectomy still the gold standard?
It's an even harder question, right? So first let me second, what you started with, and I think, really very, very happy, super happy to be here in New York finally after COVID. It's just phenomenal feeling to come to this meeting. It's, to me, and to many of us, it's probably the most favorite meeting that we do every year, and we look forward to it. So thank you, Frank, for making this happen. As far as the CEA versus TCAR, and we've done a lot of the work, and many others have replicated and came up with very similar results. We know that TCAR perform just as good as CEA, even in high-risk patient, and with multiple publications, including the one in Annals of Surgery, where there was no difference in the risk of stroke, there was no difference in the risk of mortality, and there was even a slight reduction in the risk of MI. And then this was also extended more recently, new publication, to 1 year follow-up, with similar outcome. I think, CEA, it's always going to be one of the most favorite operations that vascular surgeons do, and it's gonna stay around. I don't think it's going to disappear, but I think TCAR more and more just showing that it can perform just as good even in high-risk patients. And then more recently with the work that you're doing, Mark, showing in sub-analysis that it performed well also in standard risk patients. So it's hard kind of to ignore the evidence in a way. There's no question that we can do TCAR much faster than CEA. I would say half the time for me at least. And the clamp time is also at least 1/3, compared to CEA. We all talk about, what is the long impact on the patient cognition. The neurologists always like to think about that, like when you're clamping the carotid for 30 minutes, 40 minutes with CEA versus 10 minutes. We are talking about, I think there are going to be more and more evidence on DWI comparison to CEA, and to see what is that going to affect long-term as far as patient cognition and function. So I think these are all questions that we still need to answer. I still think that we need to do randomized trial. That's my humble opinion, because I think we all been trained, and we all think as vascular surgeons that we need level 1 evidence, and everything we've done so far is retrospective. the second best thing, with propensity score matching that you did and I did and others, but I still think we need to kind of go forward with a prospective, randomized fashion and compare the two and see what happens.
Dr. Dua, how do you fit TCAR and CEA into your practice and your teaching of your trainees?
The way that I actually fit it in is actually I'm bringing it back to the patient, which this is really the only area where truly I sit down with the patient and have a conversation with them and spend, not that I don't talk to them about other things, but this I really say, we don't know exactly. There's no randomized control trial, but this is the current data. And, stents are something that we do in other areas of the body, and they've really taken over, up to 90% of our aortas are now done that way. Obviously, peripheral, all over the place, we're using stents. And so it makes sense that this is the last frontier where we're going to say again that stents might be the right way to go. I explained to the patients the short duration of the procedure, how it doesn't really burn any bridges, and how really it's the same benefit as a CEA. We talk about the risk of injury to the nerves, of course, and the fact that that's going to be reduced when you're doing a TCAR, and that the big thing is not burning any bridges. And so patients have really been the ones that guided me and make me decide whether I want to do a CEA or, because some of them come with preconceived notions. They've had someone in their family who's had a CEA, they want the same operation, but I'll say anecdotally, overwhelmingly, the patients want stents. And so I've been using TCAR most commonly in those patient populations. In terms of the trainees, they also want to do TCAR because they want to learn it. So we've actually seen a major uptick. Mass General was one of the first places, as you know, where we were doing a lot of these cases, and now we're seeing a big influx of these patients again.
I mean, you were a leader with looking at the standard risk. So could you maybe tell us more about these analysis? How is TCAR performing in standard risk? Since we already know now, how does it perform in every patient in the past was high risk criteria? And now
Yeah. For the standard risk patients, results were quite similar to what you found in the high risk group. To get to the standard risk, we increased the age limit cutoff for what was high risk to 80, and that allowed us to get a lot of patients that had been entered into VQI into a standard risk analysis. And we found equivalent stroke or death rates, just like you did in the perioperative period and out through 1 year. Now, this was an analysis mandated by the FDA, so their primary outcome of interest was 30-day stroke, death, or MI, and then ipsilateral stroke out to 1 year. And the difference was negligible between the two, not at all statistically significant. So equivalent results with, once again, the lower rate of MI and, more importantly, the lower rate of cranial nerve injury, which I do think factors into things. And for me, when I'm choosing, for a lot of the time, it's a coin flip and it's up to the patients. But a lot of them, I find, do care about the cosmetics, and I think the small transverse incision above the clavicle is a much nicer cosmetic results compared to the standard endarterectomy. And so, and that with the reduced cranial nerve injury, I do think that, I see most of my patients opting for TCAR when I tell them that everything else seems to be equal. The other thing that I do is there are people at both ends of the spectrum, some people who have a really high lesion that would be a struggle to get to. You can get there, but it's going to have probably a higher rate of cranial nerve injury to get up really high. And so TCAR is really easy then, because you have this nice long distance from the clavicle. And if it's low, if it's less than 5 centimeters from the clavicle, then, rather than put a conduit on, it's just a really simple endarterectomy. And I now find the bifurcation with duplex, mark it, and make a small transverse incision in a skin crease, even for my endarterectomy patients. So they're all getting cosmetic improvements out of it. And so hopefully they're happy, and I think the results are pretty good.
This particular, cosmetic and patient feedback, we always, think that we know what's best for the patient. And I think, we need to start more and more thinking what the patient wants and what the patient thinks. For us, it's like, I said, just 5% cranial nerve injury, most of it resolved. We know that some of it doesn't resolve. We know that few persist for a long time. It's very, very disabling. I have very few patients that had to happen, have to have bilateral and end up one side CEA and one side TCAR. It's just like the best randomized trial you can do. And then when you talk to the patient about their experience, they tell you that it's night and day. For us, we always say, we can do CEA, very small incision, like you said, right focus it with the ultrasound. It's still for the patient somehow this TCAR incision, the whole experience is much, much better. So this is why I think, like if we do something like a randomized trial, we should not be looking only at stroke and death and MI, because we know they're not different. We've done this. Nothing going to change with randomized trial. But I think we need to focus more on what the patient think is better. Quality of life, cognitive testing, and whatnot.
Yeah, I think that's a great point. Anahita, any final comments?
No, go TCAR. And I am all about cosmetic results as well, so I'm happy with that.
All right, thank you both very much. Enjoy the rest of the meeting.